Good morning, everyone. Thank you so much for joining the Maryland HIMSS event. We're going to give folks just a minute or two to join us. Okay, I'm going to give them about 30 more seconds and then we'll get going. The folks are still connecting. All right, well, good morning, everyone, and thank you so much for joining our event today. Today, we're going to be talking about leveraging COVID immunization data, and I'm sure all of you, just like us, have had vaccine on the mind for the last year, and certainly our speakers today have been deeply entrenched in this topic and have a lot of great information to share with us. We have Claire Hannon and Anya Fries and Mark Mooney, and I'm going to let them introduce themselves to you all and tell you a little bit about themselves and what they do, and let them jump right in. So with that, I do want to take a minute to thank our sponsors. If you want to switch slides, Amanda. Our sponsors are a necessary part of delivering these events to you and the other collateral that we bring to the membership. And so we are so thankful to have them as partners. And so I encourage you all, if you have an opportunity to meet any of them, to give your thanks as well. Next. All right, so Claire is going to kick us off today, and she is the Executive Director of the Association of Immunization Managers. Claire, take us away.
So thanks, Jennifer, and thanks for having me today to everyone. Just, I guess my bio is I've been working in immunization for a long time, since I was in kindergarten, 20 years or so. And I'm a graduate of Wagner College, the best college in the universe, woohoo! And also from Johns Hopkins here in Maryland. So next slide. We'll come back to her, but you can see her background. Anya speaking, and then Mark. Do they want to introduce now, or no? They'll introduce during their time. Sorry about that. Okay, so I'm going to sort of give a kickoff national perspective, a sort of overview of immunization programs and the data systems they use. I am Executive Director of the Association of Immunization Managers. We are a national nonprofit representing state, territorial, and large city immunization programs. There are 64 federally funded programs, so programs that get money from CDC, 50 states, 6 large cities, and 8 territories or federated states, and that's who AIM members are. Next slide. And I'm just going to cover the immunization program, the basics of how they work in states, immunization information systems, the data they use, the pre-COVID environment, and then the impact of COVID on IIS and immunization data, and then the future vision for these data systems. Next slide. So just routine activities for an immunization program. Your state immunization program is going to be responsible for implementing and overseeing the Vaccines for Children program, which is a major public program for kids 0 to 18, in which the government provides vaccine and it's given free of charge if you're qualified. So about 50% of the nation's kids who are on Medicaid or uninsured. This involves enrolling private providers and using private providers to give the vaccine, managing inventory data, all of that. And this program was used as a model for the COVID program that then involved enrolling adults and all of that. So this is a big responsibility. They also do outbreak control strategies for increasing coverage rates. Of course, all the stuff with data collection and analysis, immunization education, and the COVID vaccine program did also fall to state immunization programs. Next slide. I just wanted to give you a sense that these programs are largely funded by CDC. So some states get some state funds, but many do not. Maryland does not. And so what they get from the CDC is what they use to manage their program. And this funding has been level for the last 10 years or so. And I point that out to you to say that, you know, it's very hard to invest in data and technology and to maintain your immunization information systems and enhance and modernize when your funding is level. So that's just one of the things I wanted to show you. Next slide. So what exactly is an IIS? You may already know this, but in case you don't, so we're all on the level playing field. The immunization information systems are confidential, population-based databases that record all of the immunization doses administered by providers who are enrolled. And hopefully each state is working to get all of their providers that are giving vaccines enrolled. And yes, within a geopolitical area. So it's mostly statewide. Next slide. This is a detailed look at all the things that IIS can do. It's not just tracking doses, it's managing inventory and all these other things. I'm just going to skip over this in the interest of time, but you can go back if you would like more information to see this. Next slide. And this is also just, I'm not going to dive deep into this, but just that there are multiple different platforms, but it basically falls into 4 categories. So there are 3 platforms and then a homegrown category where states have developed their own immunization information system. Next slide. So the pre-COVID environment, every state IIS is different. It is data collection and gathering at the state basis, except where we talked about the territories in those 6 large cities. The funding has not kept pace with the needs. I think I showed you that. The data sharing with the federal government and between states is limited. So we don't have a system, we didn't before COVID have a system of sort of national tracking. If you wanted to know the national immunization coverage rate for measles or Tdap, you could look that up on the CDC website, but it would be from the National Immunization Survey, which is a telephone-based sample survey. So we did not have sharing of data of doses administered from states to the federal level pre-COVID. We also have a lack of standardization. Like every state has developed their own system to support their state needs. And so not every system is the same. One of the biggest challenges is getting providers to report their doses administered. Some states have a requirement for providers to report, but many don't. And so that's a big challenge. And so states have been using the Vaccines for Children program to require those enrolled providers in that program to report. But this is an ongoing challenge. And then there's been limited consumer access. So for you to check your own immunization record through the IIS platform, that was limited pre-COVID. So next slide. So just the impact of COVID, first of all, a lot of emergency funding given to states and states using that funding to invest in their IIS, in their data systems. COVID vaccination data sharing from every state to the federal government. That's just an incredible achievement. Data analysis and public facing dashboards. So the first time really states having the capacity to conduct analysis and to put that information on their websites to the public. Providers required to report doses administered. So here, in the case of COVID, we're providing the vaccine for them. In exchange, they have to provide the doses administered information back. Increased consumer access. We're seeing that now as you need to prove you're vaccinated to travel and other things. and increased data sharing between states. We're not all the way there yet, but it's improving. Next slide. This is just to show you the growth in volume of daily data submissions to IIS nationally. And you can see that it's huge, the number of data, how COVID has impacted, the busyness of IIS. Next slide. So I just wanted to show you some snapshots of the data dashboards. This is the national one, and it's not perfect, right? But this is the first time that we've had any kind of national tracking of immunization coverage rates that you can look at in basically real time. So this was really huge, and I love looking at this data tracker because it gives you, it's positive, it gives you hope, it shows you how far we've come, and it's really amazing. Next slide. I have some sample dashboards that states have done, and you're going to hear more about the Maryland experience on this webinar, but this is a snapshot of Maryland's. Next slide is a snapshot of California's, and you can see in California they're breaking it down by county, they're breaking it down by pharmacy, other really interesting ways to show the data and analyze the data, and this is great. Next slide. This is an example from Alaska of their data dashboard. So it's been really great to see these data dashboards for COVID vaccine. Next slide. So the future considerations for IIS, consumer access, either with digital certificates or QR codes. We're seeing many states move forward in this area. This has become kind of a political issue, and so some states are having struggles with that, but hopefully, we get to an area where, people can access their own records digitally. Sharing of data for all vaccinations, not just COVID, on a quarterly basis from states to CDC. And this is actually a requirement in the new grant period. So I talked about states getting their immunization funding from CDC, and with that funding comes requirements. And connecting to the IZ gateway and growing that capacity to share data on all other vaccines is a requirement in the next grant year, which starts in July. Sustainable funding dedicated to IIS. So that funding that comes from CDC, there's going to be a specific stream now for IIS, which is exciting. Hopefully we can get Congress to give more money so that, there can be more money, but at least we have dedicated money. And then modernization, standardization of systems, continuous work in that area, incentives for data sharing and provider engagement. Make sure that providers are giving that data in. Next slide. This is the last slide, and I just wanted to show you that the immunization community, which is their national organization, is the American Immunization Registry Association, is having all of these discussions around the future and road mapping. So if anyone's interested in getting engaged, and this really focuses on making improvements in 5 different areas: data sharing, the quality of data, standardization of systems, creating that national trusted source where we're actually getting doses administered, we're not relying on a telephone survey, and modernizing technology. So next slide. I think that's it for my overview. Appreciate it, and I'm looking forward to hearing from the other 2 speakers, and I'll turn it back over to you, Jennifer, or maybe it's going to Anya next.
Yep, so we're going to Anya next, and thank you very much, Claire. That was fascinating. Folks, we're going to ask you, if you don't mind, to hold your questions until the end, and we'll have an open Q&A period with all 3 of our speakers. And so, Anya, I'll turn it over to you now, and you can introduce yourself, and Amanda then will hop back to your slides for you.
Sure. Hi, everyone. I'm Anya Fries, and I'm the Director of Reporting and Analytics at CRISP. So do a lot with public health reports to support COVID, which we'll talk a little bit about, as well as reporting and analytics for hospitals and primary care practices, looking at kind of quality measures and care transformation. I guess if we're going with a proud alum of Davidson College, and also got my master's from Hopkins. So we can,
Woohoo!
yeah.
All right.
So thanks, Claire, for teeing this up. I think it's kind of a really nice flow. What I will be talking about is how CRISP is getting that IIS data from the Maryland Department of Health, working collaboratively with them to support use cases like the public website that Claire showed, as well as other reporting and analytics and some of the successes and challenges that we've had. So if you want to go to the next slide. For those of you who are not familiar with CRISP, we're Maryland's state designated health information exchange. So we work very closely with hospitals, practices, post-acute facilities to exchange information and creating more transparency in terms of patients' medical history so that providers don't need to ask the same questions every time a patient comes to seek care. We're also have an affiliate model with affiliate HIEs in other states, as you can see on the slide. So if we go to the next slide, this is I'm not going to talk to the data diagram, but this is just kind of a high level overview for the COVID vaccinations to give you a sense of the number of different inputs that are coming into CRISP, the way that we are able to match it and integrate it with other data sets. And then on the right side of the data diagram, kind of the push to other downstream systems to really have a coordinated set of business logic and coordinated data for the state to be able to get insight across different reporting and analytics streams, whether it be the public website, internal reports for decision making, or reports for local health departments. So if you want to go on to the next slide, I think some of the so talking, I guess, through the data flow a little bit, but and some of the successes we've had is we work really closely with the Maryland Department of Health Immunet team and have a daily pipeline that sends all of the COVID vaccinations into CRISP every day. When we get that data, we are able to enrich it. And so some of the things I think that I kind of want to highlight that we're able to do there is, for example, filling in missing race and ethnicity data. So one thing that's been, really important for the state and local health departments in COVID vaccination response is ensuring equitable distribution of COVID vaccines. And so CRISP has a master patient index that allows us to track one individual across multiple data sets. And so we're able to leverage some of the clinical data within CRISP to fill in missing race and ethnicity values that may not be complete in the Immunet data to really round out that picture of what are the disparities in vaccine access across the state. Some other examples of the processing that CRISP is doing is geocoding the data to take the addresses that are submitted in the Immunet data and then be able to really drill that down into, for example, a census tract to allow local health departments to do door knocking and outreach campaigns. In addition, we are putting in centralized business logic onto the data, for example, to look at, to count the number of doses and boosters, or to have a standard set of population denominators that are then used in outputs across CRISP reports, MDH reports, and other use cases. And so some cool use cases that I kind of want to highlight is one, sending the data to Maryland Department of Health to back that public website that Claire had shown. We're, kind of doing this on all of the COVID data every morning, getting the immunization data at around 3:30 in the morning with all of these files outputted by 7 a.m. every day, and have a whole great team that supports that, which I think when you think about kind of the volume of data there is pretty incredible. We are also able to link, which I'll show kind of some examples of this later, but able to link the vaccination data with information that providers submit to CRISP about patients who they treat, to allow them to identify individuals who may need a vaccine that they need to outreach. And then another kind of fun use case that CRISP was able to support during COVID, that I think is one of those stories of something we never thought we would do, is in the early days when the vaccines were released, everyone was signing up for those wait lists and those registration lists to be able to get a vaccine. And so health departments and hospitals reached out and said, we're calling people on these lists, but people have already gotten the vaccines and they registered for 20 lists. Can you help clean up the waiting lists so that we're only calling individuals who haven't been vaccinated, and can prioritize our staff's time? So if we can go to the next slide. So kind of some examples of reports that we have built out using the vaccination data, and making available through our CRISP reporting services portal that's available to providers and hospitals is a report called the Vaccine Tracking Service. And so this takes, for example, a primary care physician's list of patients who they treat that they send into CRISP, marries that up with the vaccination data, as well as some other chronic condition data that we have in CRISP, and allows those physicians to filter down to identify, maybe individuals who haven't received a booster and have chronic conditions and who they would like to prioritize to get into their office to get that vaccine, to really support providers in ensuring that their patients have COVID vaccinations. And then if you want to go to the next slide. Another example of reports that we have built out are supporting local health departments and looking by zip code and by census tract to identify areas with low vaccination uptake to really drive those outreach campaigns, as well as looking at disparities in vaccination rate by zip code within different racial or ethnic groups to be able to identify zip codes that are having high disparities in vaccine access. And if you could go to the next slide. So here's an example looking at Baltimore City by census tract. So it's a lot more granular and has been used to support mobile vax clinics. If you want to go to the next slide. Oh, okay, so maybe the last slide got dropped, which sorry, I didn't realize. The other points that I just wanted to raise were some of the challenges that we had in working with the vaccination data. And one of the challenges that we've had to work through, for example, is that in the raw data that's coming through from Immunet, there is no dose indicator. And so we worked really closely with Maryland Department of Health and the Immunet team to come up with business logic to identify what's a first dose, what's the right timing interval for a second dose, and then now with boosters, fourth doses for individuals who are immunocompromised, there's, it's always evolving, and kind of new challenges present itself in such a large data set when trying to identify these kind of clinical concepts in the underlying vaccination data. The other challenge that I wanted to highlight, which is relevant to this report, is that population estimates can be really challenging. When we think about percent of population vaccinated or percent of population that's not vaccinated, we don't really have precise counts of the number of individuals who live within a specific zip code or live within a specific county. And there are many different data sources to look at those population estimates. And so it can be very challenging, especially when communicating with the public or communicating with individuals who maybe aren't, data nerds, that because one report says that 85% of Maryland is vaccinated, the other one says that 83% of Maryland is vaccinated. One isn't right or wrong. It just depends on kind of those estimates and assumptions that are going into those measures that you're calculating. And so kind of communicating that and explaining that can be really challenging. So that's all that I had for you all today. Looking forward to the Q&A, and I'll turn it over to Mark.
Thanks, Anya. That was terrific. Looking forward to being able to ask a few questions of both of you. And our last speaker today is Mark Mooney from Priority Partners MCO. And Mark, I will let you introduce yourself, and looking forward to hearing from you.
All right. We have problems and started the meeting. So can you hear me okay now? Before I continue?
Yeah, pretty well.
Yes.
Stay right up on that microphone.
Okay, I won't lean back. All right, my name is Mark Mooney. I work for Johns Hopkins Healthcare, Priority Partners Administration. Been with them, Priority Partners, for 10 years now. Started out in IT, moved over to the MCO, and through my experience and growth, I've been able to combine both my IT experience with my curiosity in informatics and healthcare. For those who may or may not know about Priority Partners, it is half owned by Johns Hopkins Healthcare and the Maryland's Community Health System, which is the group of FQHCs. And we have over 346,000 Medicaid members from the state of Maryland. Everybody else was talking about their colleges. I graduated from, I guess it's Towson University now, Towson State when I graduated. And I got my MBA from the University of Baltimore. And one of my primary roles with this COVID is just the provider monitoring, providing the providers information, helping internal areas as far as tracking members who are in need of COVID vaccines, and when required, providing information to the Maryland Department of Health. Vaccines were not a real big part of my role prior to COVID, and now it's a very high priority. You can go to the next slide, please. So it was very interesting hearing the two previous speakers. I honestly was not aware of how we were all linked until we decided to do this presentation. Of course, I knew I had a relationship with Chris, because we go with Chris beyond just COVID, but I did not know how the IIS fit into Chris and therefore to me. So the interconnectivity is something I learned today. For our reporting purposes, we have 3 data sources for data, with CRISP Immunet file being by far the most important. The CRISP file, we have our PBM, which is Caremark pharmacy data. And we have our fee-for-service claims information, data that gets fed into our warehouse. The challenge for me is to create one reporting area table so that we can produce reports for the entities that require them. When we get to CRISP, we get the files daily, and our IT sends CRISP a daily roster each day. Then they in turn we send the file back with all of the COVID information that then gets loaded into our warehouse and scrubbed so that we can do reporting. And like I said, that is, I guess I made a mistake. I thought it was weekly, but it's nice to hear that it's daily. That's my apologies. The pharmacy data is something we get is bi-monthly, gets fed into our warehouse. And the pharmacy data, I use, not CPT totals, I use the NDCs and use those and group practice identifiers so that I can identify the proper vaccination shots to use into my data. I don't want to accidentally include any other vaccines. And finally, with the fee-for-service information, we use the CPT codes, both for the vaccines, which are 9 series codes, and we use the administration codes, which all, I believe, start with 0 to track which vaccines are being used and which dosage was being done when the providers providers submitted the shots. You can go to the next slide, please. One of the things, like I mentioned about COVID and CRISP being the primary data source. So overall, out of the 3 sources, over 90+% of the information comes from CRISP. There is a lot of overlap between CRISP and pharmacy, and trying to make sure I don't do any duplication of shots or making sure that the members' actual vaccination rates are submitted properly. The pharmacy data itself has 9% of our claims, our member shots that aren't in CRISP, and fee-for-service trails with maybe 2 or 3%. What the biggest thing that I try to do with this when I'm doing the reporting, is to make sure that I don't duplicate. So for example, even though I will find the same numbers in the CRISP and pharmacy data, sometimes the dates are different. It could be a day or 2 off. And if you're not careful, you can accidentally say this person had multiple shots when they really only had 1 shot. It's just the way that the provider or the vendor is submitting the data. So I have to scrub that. You have to make sure that the pharmacy shot as related to the administration, you don't want to count the administration and the actual drug separately, because you'll overstate your shots, and you don't want to miss the opportunity to provide the providers that, this person had 1 shot, not 2 shots. So make sure they have the information to get them boosted. Another problem that we have sometimes is body site codes, or left arm, right arm. You'll have data to come in, and you'll see that they said the person received shots in both arms on the same day. So you just got to scrub it and make sure that, make every effort possible to make sure that the data is reporting the shots properly. And with that, what's one of the biggest challenges with the data. And another reason we have to combine all this data is the CRISP data does not have cost information in it. And that's one of the things that the MDHIMSS tracks for us that we have to submit to them regulatory. So I have to merge the data, make sure I don't overlap, and keep the tracking straight. When we share information with the providers, that's somewhat of a challenge, because all of our data is at member level, so we have to be secure and protective members' information. So when possible, we send it SFTP secured through the provider directly, not over the internet for security purpose. And we're often limited that way with some of those things, because some of the providers, particularly the smaller providers, they don't have the necessary technology to exchange data. So we work sometimes with our internal staff, provider relations, and in other areas, and within the Johns Hopkins Healthcare, to provide data to the providers on their members. Next slide, please. So finally, we have these 4 entities at the bottom where I exchange data the most. The MDH, they really want to keep track of cost, and we share with them vaccine administration rates and costs and members, and they provide us templates that we have to supply to them through Hilltop, and they keep track of us that way. The providers, like I said earlier, we do FTP when we share with them the member level information, as particularly the number of shots, who's eligible for a second shot, who who has a booster, who doesn't. It's becoming more of a emphasis, particularly with the children, since they can get vaccines now, tracking those. The members, we don't provide them information directly. We do have two areas within member services and customer service. Member services handles inbound calls, and we share with, and they receive their information through Epic from CRISP of opportunity. So if a member call in wants to change their address or have any other questions, they take advantage of that opportunity to look at the members' records and see where they are as far as their COVID status, and encourages them to go to their providers to get a vaccination shot. Customer service, they too do the same thing. So if a member calls in PCP change or any type of inquiry, we take that opportunity, take advantage of it to reach out to that member to see if they want to register for a vaccination shot. One thing I failed to mention with the MDH is there's an incentivized program with the members to encourage them to get their shots. And when we have members who meet the incentivized dollar, we then have to report that to the state so that they'll know how much we've spent on that with their money, because it's really their money on these programs. And finally, we have finance, and that's internal. That's more, I mean, it's not related as much to the vaccine costs, it's to the testing. And that is another facet of COVID, of course, where testing has become a very expensive undertaking for all the MCOs, because members who choose not to get vaccinated, we're still obligated to make sure their testing is paid for. And if they get multiple tests a day, a weekly basis, those get submitted to us and we have to pay for them. So that's how that works for us. If I had to, one thing, I'm glad that I'm on this panel, because I really appreciated the two panelists, particularly from Chris, because there are opportunities there for all of us to collaborate better, to provide information to the providers in particular, so that the members can get their shots and we can get over this pandemic. I think that's it for me. I don't think I have any more slides.
Thank you. That's terrific. I appreciate all three of you. It really did a wonderful job. It was interesting, Claire, when you were talking about the immunization registry, or IIS, and the level or lack of sophistication from state to state, the lack of standardization, et cetera. A decade ago, I know we were struggling with meaningful use, and one of the requirements was around, electronically exchanging immunization data with each of with our states, et cetera. And so, any thoughts on
I just lost you, Jennifer.
Yeah, I don't hear anything.
You said any thoughts on, and then I didn't hear you.
Y'all can't hear me.
I just heard you now. Yeah.
You heard me now?
Yeah. Can you just repeat that? Any thoughts on?
Well, just was it effective? Are there other initiatives that could perhaps incentivize and enhance the state level, and because we really, it sounds like, obviously need a national program, right? And how do we get there? Just like we struggled through this with EMRs and et cetera.
Yeah, that's a really good question. So the meaningful use, I think, was very successful and provided a lot of incentives. At the same time that the meaningful use was going on, I think that there were lack of funding on the state public health level in order to enroll all of these new providers coming on, and in order to build systems and make them better. So it would have been really good. We did have some separate sort of competitive grant awards from CDC to some states. Some states were able to really do more innovative things around enrolling their providers that were coming on through meaningful use. And I think that was really good. There is some things that the Biden administration is trying to encourage, and their Office of the National Coordinator, or ONC is what we call them. They are doing some programs that are incentivizing data sharing across states and with HIEs. And we've been a part of that project. It's called IDEAS. And so there's going to be about 7 or 8 states funded to work with their HIE to build that data sharing. There's also been some funding that has gone to the IIS vendors that I showed in order to assist the states that they serve to connecting to the IZ gateway so that, they can be sharing information. It was really exciting to listen to what's going on in Maryland, and CRISP having more than just Maryland and really doing so much with the data and working through a lot of those challenges. So I do think that federal incentive money does really help. And I hope that, that it'll continue to come and, make a difference.
Thank you. Anya, did you have any thoughts on that? Are you all seeing any kind of incentive programs or funding coming your way to help try to drive a national data exchange around this?
I'm not as familiar, I guess, with that kind of landscape. We are, we're focused. I'm more familiar with kind of partnering with Maryland Department of Health, but a little bit less in terms of the national landscape.
Okay, we have a question here from one of our members who says, since there's an information system set up, does it get used to collect other data like mortality related to COVID or other COVID related data?
I can speak sort of on the national level, the immunization information systems. There are a few that collect other information like birth defects or BMI or something like that. And I think, I don't know that they have been used to collect other information around COVID. So I couldn't answer that. Anya might be able to talk about what CRISP does in Maryland.
I can. So in terms of COVID related fatalities, that's collected typically by the Vital Statistics Administration. They review the causes of death and decide whether or not that should be attributed to COVID. And so they have kind of the data of record for COVID fatalities, and they share that information with CRISP so that we can do that linking that I've been talking about, to link it, for example, with vaccination records to say, okay, well, of fatalities, who's been vaccinated, who's unvaccinated, or link it with the confirmed COVID cases to look at that progression between when they first tested positive for COVID and when they ultimately passed. And we share that back with the department so that the epidemiologists are able to track that data longitudinally.
So when we hear in the media that, patients presenting in this last surge, they gave percentages and numbers of folks that were unvaccinated versus vaccinated with serious COVID infections. Is that data coming from you guys? Is that coming out from those kinds of data joining, or is there coming from someplace else?
So I know we do support, for example, on the Maryland Department of Health website, they have a post-vaccination infection section. And so we do link that data and share that with them. so that they're able to put that on their website. Other states, I'm not quite sure how they're doing it, whether it's through linking data sets. I think some other states are doing it through their contact tracing departments, where when they're calling those individuals
Mhm.
to investigate those confirmed cases, they're asking about vaccination status.
Okay, I have another question from the audience. It says, is IIS working directly with major EHR vendors to come up with standard data transfers via integration and or data pools to accomplish principle number 4 and 5? Pretty specific, Claire.
Yeah, so the big answer to that is yes. The little answer to that is that, you know, there are so many EHRs, and the standardization, you know, some EHRs collecting information on race or ethnicity, other, you know, like not, but that standardization, that community is all working together. And the ERA immunization registry group is sort of coordinating that and has strong relationships with the EHR vendors. As you can imagine, there's a lot of complexity and challenges there. They're doing use cases, I think, technologies speak that not all familiar with, but ERA is going to be at the HIMSS conference. And if you're interested in that, yeah, strongly encourage you to look for them. And that is going on, that work within community of IIS and EHRs.
Great, thank you. And James, thanks you as well. All three of you kind of touched on consumerism. You know, COVID vaccines are obviously very important to the consumer for work, for travel, et cetera. Can you all speak a little more about perhaps the challenges or maybe some of the use cases, the successes around getting this data in the hands of the consumers and making it accessible?
I will jump in and start that off and just speak about a few of the challenges. So one challenge is standardization and having standards for producing a digital certificate. We did have some of the IISs allowing consumer access pre-COVID, but they didn't necessarily have a digital or a QR code or something like that. You could look up your record for all the vaccines. It wasn't meant to be like, let me show this to get into a restaurant. So, you know, that has sort of, that need has arisen with COVID. And one of the challenges then is that you have different vendors, right, taking the different approaches, and there's no standardization. And so there has been a project to use the smart health card with VCI to kind of standardize that. In some states that were already under contract with their own vendors, you know, there've been challenges trying to meet that standard. And then I also mentioned the political challenges, right? So that, you know, states that don't want to enter into that realm of mandating vaccines, you know, they've been portraying that as, let's not allow a digital certificate because it might be used to meet a mandate. And so that's also been a challenge because, you know, your immunization record is your immunization record, and just getting it digitally, that's not the same as mandating it, but it does fall on how it's used. So those are the two big challenges I can think of. And I don't know if anyone else wants to comment about particular local challenges.
I would say is one other challenge that I could imagine, I guess we're not as much on the consumer side, but is that especially in Maryland, federally administered doses are not reported to the state immunization system. And so if you think about Maryland and the VA or Department of Defense and a lot of the military bases that we have and federal employees, those immunization records aren't in the state system. And so I don't know in that kind of future state, if you needed to get a digital card, how you would go about doing that.
Yeah, that's a good point. And also, like, if you're in Maryland and you got vaccinated in DC, they share. But if you got vaccinated in Pennsylvania, they don't share yet. So, but those are, those are all the things that are on the horizon to get the federal agency data into the state systems and to get the state systems to be able to share.
Super cool. Oh, Jennifer, you're on mute.
Thank you. Sorry. Yeah, I want to thank you all again. This has been terrific. Oh, it actually looks like Marissa has a question. Beyond the work that's been done in response to COVID, how do you see all this work being used for other issues, pandemics, health concerns going forward? And what can be reused, so to speak?
Yeah, I'm happy to jump in. I know, and then Claire, I'm sure you also have lots of thoughts. One thing that we've been thinking about a lot at CRISP is how can we expand the work that we have done to kind of link the data sets, make that available to MCOs or providers? How can we expand that to childhood immunizations? And so getting more robust immunization history to be able to identify gaps in care for primary care physicians and pediatricians especially.
Yeah, that's really good. And I think the way that we've seen the data analysis, like by zip code, and knowing like this school is could potentially be a threat, like you can identify areas where there might be more danger than others for a new virus variant or something like that, or hospitalizations rates. You can sort of look at the data. You can look at it by population, you can look at it by location, kind of identify those areas that are more vulnerable, and knowing where to put your resources. And yeah, I mean, I think you can also look at that as far as future pandemics, lessons learned, and how how the vaccine was accepted or not accepted in certain areas. I think all of the data they're collecting is very helpful. Either inventory data, the storage and handling capacity of providers who enroll. One of the big challenges was that the vaccine orders are huge. Like you would order the Pfizer vaccine in 300 dose minimum. And so states have had to really break that down further, and just having all that data, knowing that for a future pandemic or a future vaccine rollout, having all the providers enrolled, having this database of adult providers, these are all big game changers as we move forward with health and vaccination.
Very much.
From my perspective, one of the biggest things to take away from this is it's not just for COVID, it's more of a comprehensive view of each member or the provider. So, and how you can, for lack of a better word, take advantage of the information. So for example, in the state of Maryland, we have our live-based purchase and HIMSS measures. And when you combine those opportunities with the COVID testing, it just gives the providers a more broad view of the members that they have and what they have to deal with. And when you have these COVID opportunities, or like I mentioned earlier with our member services, if you have those opportunities with a HIMSS measure that can be fulfilled, you can piggyback on that and ask about the COVID testing. I mean, not testing, vaccination. It's just, when I look at it from my perspective, it's more, the more information we can provide the provider, the more information they have on their members, from their perspective, their patients, the better. And trying to eliminate any blind spots or lack of information, for just more comprehensive universal care for their members. I'm sorry, patients. I got to think about the way they view the members. Sorry.
Yeah,
it's just a bad
that's
thing.
awesome.
All right, great. Well, thanks again very much. We're just going to move into real quick some announcements, and then we will have a door prize. and you must be present to win. And it's $100 Amazon gift card. I'm gonna turn it over to Phil Campbell, the president of our chapter. Phil?
Hi, Jennifer. Thanks, everybody. I wanted to just talk about a couple of things. One, we're really kicking off a lot of different professional development initiatives. So stay tuned for that. Lots more virtual events coming up. We're going to try to get in person at some point. One big thing for you, I put it in chat. If you're going to the Global HIMSS conference in Orlando would love to see you on March 14th at 8 p.m. at the pub at Point Orlando. You have to register. I put the link in chat as well. And then the final thing there, the HIMSS Hero lapel pin. We're not going to say a whole lot about this, but let's just say we're working on a way to recognize all of you who've put in so much work during this pandemic. We want to recognize you in a meaningful way. And so we're working on that, and our IT leaders who are on the call, please reach out to us so we can talk about how we're going to do that. Next slide, Jennifer. Yeah, and then elections. So elections are open for fiscal year 23. Send it to the md.info email address that we use for almost everything. We're getting the webpage updated, so we'll have all that information up to date there. But nominations are going to run for a month, and we'll have our election for next year. If you're really motivated and making a difference in Maryland with healthcare, we want to have you on board. We want leaders who are willing to lead transformation and really make Maryland HIMSS the go-to place for all of our membership. So back to you, Jennifer.
Thanks. All right, Amanda, next slide. We just wanted to mention, we have our new pillar committees this year, and this event was brought to you by our data analytics and exchange committee led by Olivia Kessler, and just what a fantastic job they've done. Next slide. Okay, I just want to give you some upcoming events. I got a lot of TBDs in terms of dates, but I do want to share with you, we have a lot of things on the planning board right now. Our annual Maryland HIT Day, we're targeting March 3rd for that. Our clinical informatics group is going to be doing an add-on event to this one, leveraging data and applications to address things like staffing shortages and some of the other COVID challenges. Of course, Phil mentioned Global HIMSS is coming up. Our cybersecurity committee is putting together an event around ransomware incident scenario and response that you'll be seeing that towards the end of March. And then we really are trying to get back in person, and we're hoping that the golf tournament on May 9th is going to be the time that we get back in person. So we encourage you to join us. And then the very last thing, I'm rushing, so please forgive me. The very last thing I wanted to do is do the drawing for the door prize $100 gift card to Amazon. And Ronald Nolte, are you here? If you are, raise your hand. And Phil, tell me if a hand goes up. Ronald Nolte from Anne Arundel Health System. No. Okay. Teresa Garrett from Calvert Health. Are you here, Teresa? Or Teresa? Yes, Teresa. Anybody? Teresa, are you there?
They've gone to your pub meeting a little early.
Yeah, well,
I love that you guys are meeting at the pub.
Yeah. Okay, and the last, let me try it one more time. I drew 3 randomly. If I have to go back to the board, I'll do it afterwards. Nicole Hedrick, also from Calvert Health. Nicole, are you there? Come on, Nicole, be there. Raise your hand. Okay, I'm just gonna make sure nobody dropped anything in the chat. Okay, so I'll go back to the randomizer and draw based on the registration list and reach out to that person individually. Because our time is up. I want to thank you all, and hopefully we'll see you soon. And a big thanks to our panelists. Bye-bye, everyone.